Okay, hello everyone. It's a pleasure to be here presenting this Glaucoma and Cataract Symposium. At this time we will have Dr. Karl Brass from Germany, Dr. Paul Singh, and Professor Elizabeth Mesmer, also from Germany. They'll speak about some very interesting things. You know, when you think I'm coming here to hear something about capsulotomy, SLT, and IPL, it should be bored. No, for sure, no. It's a good opportunity to hear the new trends, the new options that we have at that time, and to discover what is going on in the development of new technologies and new techniques to perform these well-known procedures. In the very beginning, we will present Dr. Karl Brass. He will speak us about the YAG posterior capsulotomy, the final hurdle to a premium visual outcome. Thank you.
It's just forward, yeah? Forward, backward. All right. Ladies and gentlemen, dear colleagues, I'm going to talk about YAG capsulotomy. You might know, you might think, well, we know that. We do this for ages. But maybe after my presentation, you've changed your mind. Now, as I just have 15 minutes, I have a pre-recorded movie I wanted to start with first to save some time and then to discuss a couple of things in detail. So it's an 8-minute movie as an introduction into what I'm very much interested in. We need some sound, actually. This is with sound with movement.
One of the YAG laser treatment options is the cruciate pattern technique. The YAG laser is used to create a cross pattern which allows the capsule flaps to retract out of the visual axis. Care must be taken to aim the laser beam carefully to avoid pitting the optic. IOL pits in the optical axis can lead to disturbing light effects. This lens has certainly lost all of its premium properties. As a result, the patient may well have to suffer with this for the rest of his or her life. Another fundamental source of error is performing the treatment without a contact lens. The YAG beam is delivered at a convergence angle of 16 degrees from the laser aperture, which should be further focused through an Abraham contact lens. If not, we do not concentrate the energy at an optimal focal point but rather in a broad focus. These two pictures show quite impressively how this entire IOL is practically pierced right through. An alternative approach is the circular or can opener technique, where a round opening in the posterior capsule is created. If pits are created, they usually are not a disturbance because they are away from the optical center and visual axis. The freed capsule lobe is left to float in the vitreous body. It is not uncommon for this to remain in the area of the optical axis, fully oscillating with all eye movements. Fortunately, not all patients will perceive this capsular remnant. However, some will be severely impaired by it, as you can see in the following example. Before firing the laser, let us first take a look at some basic physics. The YAG laser produces a coherent, monochromatic laser beam with a wavelength of 1064 nanometers. The laser exits through the objective lens together with the two red aiming beams at a convergence angle of 16 degrees. A YAG contact lens increases this convergence angle to 24 degrees. On the one hand, they serve to stabilize the eye, and on the other they have the function of a burning glass to further increase the energy density in the laser focus to achieve plasma formation. The mode of action of a YAG laser is to bring a small amount of energy into a tiny focus for an extremely short duration of time. The resulting power generated is high enough to strip electrons from their atoms, causing ionization and an optical breakdown, which can be seen as a plasma formation with a core temperature of 4000 degrees centigrade. Let me demonstrate this in action using dry ice. The fog produced makes the process quite visible, as you can clearly see here. Now, with an awareness of the high degree of temperature anticipated at the laser focus, it would make sense to maintain a sufficiently safe distance between the IOL and the plasma formation. Many lasers include a manually controlled offset, allowing you to move the treatment beam posteriorly towards vitreous by 0.1 to 0.5 millimeters. I personally do not use this option, but focus the laser manually 1.5 to 2 millimeters behind the capsule by moving the slit lamp towards the patient. Using this technique, IOL damage is virtually impossible. In this 3D animation you can observe the formation of gas bubbles. The initial gas bubbles are highly reflective at the time of plasma formation, so that a large part of the pressure wave is bounced back retrograde towards the lens capsule. This phenomenon is called plasma shield, which leads to photodisruption of the capsule. And we can observe this phenomenon in another 3D animation. A capsule opening centered on the optical axis is achieved. Ideally, it already has the shape of a pentagon or hexagon. Now I will show you the effect from the surgeon's point of view. Here you can see the aiming beams in focus directly on the capsule. They are overlapping, forming one circle. Now pushing the focus about 1.5 millimeters further posterior behind the lens into the vitreous. Two red aiming beams are now clearly visible on the posterior capsule. An energy level of 2 millijoules should be enough to create an initial opening, and after a few shots we see this intermediate result. The following images were not created in Photoshop, but with the cooperation of this patient, who without complaining moved back and forth several times between the YAG laser and the slit lamp camera, enabling us to capture a photographic record of this real-life situation. I will now show you another photo animation of the procedure, followed by real-life surgery. Years after performing a YAG laser treatment, you will often see these kind of soemering formations at the edges of the capsular opening. You can easily avoid this by investing some extra time. You should carefully clean the surface of the capsule of lens epithelium by applying a number of low-energy laser pulses, as you can see in this animation. This will result in clean and perfectly curled capsule edges. Assuming a perfectly sized rhexis without the risk of a vitreous prolapse into the anterior chamber, I try to achieve a posterior capsule opening between 5 and 6 millimeters.
Thank you very much. A lot of information, and I'm not finished yet. I have a course book, a handout. I don't have one for everybody. Whoever wants to come into the Quantel booth afterwards, I will be there at 2:30 p.m. and can give you a personal one if you are interested in. Right, now I have 6 minutes left, and I would like to use the time and to show you as much as possible. Now, I think that if you sell a patient a premium lens, you shouldn't leave it like this. It's your fingerprint, and this is what I see very often. And I think this is a case where there was no PCO. It has been done. These are court cases. This is, for instance, a floater was done with a circular technique that can be extremely annoying to patients. And here in particular, you see cases where a contact lens was not used. I don't call that pits, I call that drills. You create drills through the entire IOL. And I think now in these days, where everybody uses digital photography, you might end up in a court case with shitty work like this. But you can avoid it easily. I showed you. And let me show you a few more cases. If you do it primarily, I've showed you the technique. We have a new lens now with the broader diameter. We have the new laser has a posterior offset of 2 millimeters. And there is a group of patients that can have benefit from your knowledge. I call that a reshape. I'll just go through the cases right now to save time. This is an unhappy patient. I did a reshape. Yeah, the technique, patients have to sit comfortable. Patients with short legs have problems. I've created this wooden structure. If you look at your contact lenses, they are dusty and scratchy like this. I'm sure at any university department where there are 20 juniors, pick the lenses and look at, this is not good for quality. A contact lens has to look like that and can be easily achieved. I describe it in my brochure. If you do the treatment, air bubbles have to be avoided. Yeah, this looks nice, but I tell my patients it's better to leave it when you come for laser treatment. We have now new lenses. The upper image shows you PCO and a slip lens. The lower one shows you the image with an Abraham contact lens. I've thought with ocular instruments how to improve it, and we came out with a lens with a bigger diameter that is available now. Furthermore, there's a lens in development where we have decentered the plus lens to create a prism. Then you are even able to treat deep-set eyes, for instance, or patients that squeeze the eyes and where you have the Bell's phenomenon. Yeah, it's called the Brussels lens, like the Paul-Singh lens for vitreolysis. Yeah, you bring energy into the eye. Be careful what you do. This is a reshape. This is a lovely case, actually. This patient came to my practice, said, I don't see the periphery, and on top of that, I'm suffering from a floater. I did a reshape. Unfortunately, you see the damage of the IOL inside. Some people might say, well, we've done this ever. The small diameter doesn't matter. But the Optos image tells you the difference. And finally, this image, I took a movie. It's impressive. If you examine patients, you don't have to say, look at the light, but you have to change your strategy of examination. You have to look up and look down to see what is going on in the vitreous. So more reshapes. These are patients that wait for good laser treatment done in your practice. They are even more than premium PCO cases. Another reshape, another reshape. Maybe this makes you interested. And this is a premium lens. And it has not the properties, it can't achieve the properties the lens has this way. So and this is how they look in my practice usually when I do the case myself. And this is how, if you put in multifocal lenses, I'm not a fan of multifocal lenses, but if you put them in, I think the patient deserves it, that it looks like that. And it's easy. Thank you for your interest. I was speedy, wasn't I? I think now let's use the time. I showed you the movie. I apologize for that. But now I have time for questions.
If you have any questions, also it's possible, if you have any question additional, you can go to the booth.
You go to the booth.
After the presentation, the front booth, Dr. Russell will be there.
Wonderful. Thank you very much.
Okay. Brilliant presentation. We can highlight first, we have a new device that we can do as we usually do manually. We made the offset posterior. Right now we have the possibility to move it, yes, for a function of the device. Second, well know that it's necessary to use the lens and exactly the right one. And the most important feature that Dr. Brace tells us is we can perform a very clean, safe, and without floaters capsulotomy without pitting the lens in IOL Premium. Thank you so much. At the time, right now, I will present Dr. Paul Singh for the United States of America, and he will speak us about selective laser trabeculoplasty as a first-line treatment, which patients are likely to benefit the hours. Thank you, Paul.
All right. Well, good afternoon, everybody. Thank you so much for the opportunity to be here. We'll be talking about SLT and my excitement around SLT as really first-line treatment. I think to me nowadays, we've seen such an incredible proliferation of technology in the glaucoma space that we have a lot of opportunities to address compliance and really be, I think, aggressive with IOP reduction early on. And we'll talk about patient selection and the need and the reason why first-line SLT is appropriate. Show of hands, anybody here performing SLT currently? Okay, keep those hands up if you're doing it first line. Okay, yeah, so we're mixed, and I think we're still seeing, some doctors feel comfortable, some don't. We'll talk about that. For me personally, I think I've been part of a revolution, a paradigm shift in glaucoma. I'm old now. I've been around for 18 years after fellowship. And I can tell you there's a new change in paradigm and mindset around glaucoma, this idea of interventional glaucoma. But what does that mean? Well, what interventional glaucoma means to me is the fact that we don't have to always choose anymore between maintaining a high quality of life and controlling IOP at the same time. We're also able to, in other words, looking at it as addressing compliance at the same time of maintaining high safety. Right? We never had that opportunity in glaucoma before, but now instead of just drops and adding more drops and another third and a fourth line drop, we have a lot of options in our armamentarium. Whether it's SLT and other lasers, we have a lot of MIGS. I'm a big fan of micro or minimally invasive glaucoma surgery. And we have a drug delivery in the United States, and I think it's coming out here as well in Europe and other areas of the world. But the idea and the reason why we're seeing such a proliferation of technology is because we understand compliance sucks. It is so hard to keep our patients taking medications and being compliant, being adherent, coming back to follow-up, paying money for medications. It's very difficult, whether it's cost, side effects, dosing regimen, patients just forgetting to take medications. And we've seen so many different things. I've seen in my practice, if you ever want to be bored, just ask your patients to take drops in the office and see what they'll do. It's kind of scary what patients do to actually get their drops in the eye. Very frightening. But we understand that it's hard for drops to get in the eye. Only about 5% of the drop actually gets into the eye with our individual drop that we put on the eye. And we do know that ocular surface disease is a significant risk factor when you have ocular with dry eye and glaucoma. And why? Well, these drops don't penetrate, they stay on the surface, they have BAK and other chemicals. And the studies have shown the more bottles we add, the more risk we have of developing a concomitant ocular surface disease. Why is that important? Well, if you have dry eye, studies have shown, Boudouin and others have shown us, you have decreased compliance. In fact, 30% reduction of compliance if you have a concomitant ocular surface disease. We also know that BAK can cause significant fibrosis of the conjunctiva, limiting our trabeculectomy success. But also, we have seen now it can cause a trabeculitis, inflammation of the TM, even causing us to have loss of collector channel or atrophy of the collector system. And I know a lot of colleagues say, well, Paul, I don't have time to check for dry eye. I'm so busy in my glaucoma practice seeing 40, 50, 60 patients a day. How do I have the time? Well, you don't have to do much. Ask the patient, does your vision come and go? If the vision comes and goes, that's an unstable tear film. Number two, use something called a Ratten filter. There's a filter you can buy. Now, we have a slit lamp that has an automatic filter on it. But if you use Amazon, has these $10 filters called a Ratten filter, which allows you to see the tear film so much better compared to a cobalt blue light. There's a blue light, And here's the filter. And you see that EBMD, the unhealthy ocular surface. So many of my patients, I kind of let go. When I started looking for it, you'd be amazed of how many patients have concomitant ocular surface. And treating patients, you can see on the left, the tear film breakup time is less, and then you look at how much more improved after taking someone off of just one PGA. This is 3 months after SLT. So we can really help these patients' quality of vision and quality of life. But why is it so important to manage compliance? Well, we do know from many data sets out there that the more non-compliant you are, the more risk of fluctuating IOP. And if you have fluctuating IOP, what can that lead to? Potential for progression. If you look at the advanced glaucoma interventional study and others, we see the more you fluctuate, the more you have a chance of progression of visual fields. So for me, what has changed, the philosophical change, is now when I think of controlled glaucoma, it is no longer fields are stable, optic nerve is stable, and my pressures are at target. Yes, that's important, still the mainstay. But now, it's what is my patient's ability to stay on that current drug regimen and stay compliant. If I think they have a poor ability to stay on that regimen, they are not controlled, regardless of how good the pressure is at that visit. So this patient, pressure may be fine, feels may be good, but if someone looks like that coming into your office, are they really going to take their medications every day? And there are studies that have shown patients do not take medications if they have concomitant hyperemia or related issues like MGD. So my challenge to all of us, myself included, are drops really safer? This is just PGAs alone, whether it's lash growth, hyperemia, allergic conjunctivitis, fat pad loss, meibomian gland dysfunction. These are things that happen over time, and we'll hear from our fine doctor here about dry eye in general and how we have many options to treat our patients. But we have to pay attention to symptoms. Patients coming in all day long telling us, please, get me off those drops. Listen to them. If they're saying, I need samples every time, probably cost is an issue. If they say my vision comes and goes, ocular surface is probably an issue. If they say, I cannot remember the color of my top of the bottle, they're probably not compliant with their medications as well. So here comes SLT, and this is why, to me, SLT as a first line for a large number of our patients makes the most sense. It's the most physiologic way of approaching glaucoma. What is glaucoma? A disease of the trabecular meshwork, right? We do know 50% or 70% of our patients, the primary cause of resistance is at the level of the trabecular meshwork. We also have canal collapse, and we also have distal channels atrophying as well. But if primary it's TM, let's address the pathology. Let's not just bypass it using drops to the uvoscleral pathway. If we can directly affect the TM, what can we do long term to affect the natural outflow? If we earlier address the TM blockage and more flow going into the canal, do we prevent the canal from further collapsing over time? These are things that we have to understand more. But this is what SLT does. Primarily excites the level of the trabecular meshwork, right? It does not destroy like an ALT. It's a larger spot size, about a 400 micron spot size, which covers the trabecular meshwork. And unlike ALT on the left, the right, we do not see fibrosis or scarring. So for those of you who do MIGS later on, or we want to repeat SLT, we can repeat SLT, unlike ALT, because we are not causing significant fibrosis, and we do not affect the canal behind it if you're doing a canaloplasty or a stent later on as well. And the mechanism of action, just to remind ourselves, it is causing a release of cytokines, interleukins, macrophages, which really open up the TM selectively in the pigmented trabecular meshwork cells as well. So this is a natural way, my way of telling patients, this is a rejuvenation of the trabecular meshwork, of your natural drain. But I think SLT has not only a therapeutic, but a diagnostic impact. And I'll tell you about the diagnostic in a second. But how does it work? What does the data show us? And what are the reasons why doctors are not comfortable performing SLT first line? Is there still a thought there's not enough data out there to actually support primary SLT as working, and that we have repeatability? I'm going to share with you a number of data sets that really do show us primary SLT is actually probably a better solution than drops. Now, a lot of you have seen and heard Gus Guzzard's work, wonderful work for the LIGHT trial. I won't bore you too much, but it's a very important study. It basically took latanoprost first line versus SLT first line. Over 3 years, looked at efficacy. Both had similar efficacy, but in the SLT group, less patients needed drops to attain target pressure. But when you looked at things like cost, quality of life, and need for incisional surgery, progressing to incisional surgery, 0 patients in the SLT group progressed to incisional surgery versus 11 in the drop group, less visual field deterioration, less cataract surgery. So despite the same efficacy, we see less progression in SLT group. Why? Because of compliance, right? That's not the only study, though. For years, we've had multiple data sets. This is McIlrath showing us SLT versus latanoprost at a year out, showing significant stability, rather, non-inferiority to topical drops. CATS, the drop study, another very good study showing, again, non-inferiority to drops with primary SLT as well. And we do know that it does have long-term benefits. People think, well, doc, I'm not sure if it's going to last long enough. Well, number one, we can repeat it. Number two, if you do it primary early on, when you have a healthier outflow system, healthier canal, healthier distal channels, the chances of it working longer seem theoretically to make sense. And we do see that with data. This is an 18-month follow-up showing us stability. We have Jindra, who showed us, got 5-year data with primary SLT showing stability over 5 years. So the earlier we adopt it, the better chance we have of preventing further collapse, in my opinion, as well. We also have data sets showing us that, yes, we do see natural nocturnal fluctuations in IOP, but we find here with this that we actually have stability over nighttime compared to topical latanoprost in the gray. And looking at adjunctive therapy, SLT can work very well. Even those patients who are on previous medications, we can still see significant 3 millimeters of mercury or greater reduction of IOP, even as an adjunctive therapy as well. So it can be done primary and after being on a topical drop. Recently, a study came out here just now with Ganu Garg and Gus Gazard's work showing us that you can repeat. And repeatability, the second repeated after 18 months, they found the same efficacy as a primary therapy as well. So you can repeat it, and it's okay to tell patients it's okay to repeat. I think I have 5 minutes. All right. I'll go fast. This is just a little example and a video of using, this is the Tango Reflex here showing us that nice large spot size. We'll talk about kind of data on power and what's the endpoint, those little champagne gas bubbles. You do not have to find every single shot a champagne bubble. I titrate it so that way as soon as I see a champagne bubble with one of them, I don't increase it to see every single spot showing a champagne bubble. Once you see the bubble, I don't increase the power as well. But some of the pearls, I start them on 0.5 or so, 0.6 millijoules. And I go up and down depending on the level of pigmentation. The more pigmented the TM, the lower the power I use, because pigmented patients absorb the energy better and have a little bit higher risk of developing a pressure spike afterwards as well. And so I kind of vary it depending on pigmentation as well, and I use that titration of the champagne bubbles. Once I see it, then I stop increasing the power, even if I don't see champagne bubbles for every single shot I do. Now, patient selection, for the last few minutes here, I know I'm already at 4 minutes left. It is a very wide patient selection. It is not just POAG patients. Secondary open-angle glaucomas, like pigmentary, pseudoexfoliation, steroid-induced glaucoma, these are very TM-based glaucomas, are very good candidates. Post-LPI, patients have a history of LPI, now are open, who have still some chronic pressure issues. It can work very well for those patients. Just be careful of patients who've had inflammatory, uveitic, neovascularization, people who are narrow. If you cannot see the trabecular meshwork, not a good idea to perform SLT. But all those other POAG patients are very good, good patient population as well. Just for the sake of it, I'm going to fast forward through some of these, just to get through some of the other slides here. Risks. You can get a pressure spike. Again, the more pigmented you can, and the more higher the pressure is to begin with, the likelihood of a pressure spike is greater. Still very low, but that's why we check the pressure within a half an hour, an hour after the procedure, just to be safe. You can get inflammation afterwards. There's something called a SALT trial that showed us that even if you have inflammation, putting someone on ketorolac, let's say NSAID, can actually improve the outcomes compared to not using it. So I use an NSAID for about 4 to 5 days after the procedure is done. And they can get some transient irritation, headache, et cetera, some light sensitivity, which is very transient as well. And this is the SALT trial showing us that using an NSAID after the procedure for about 5 to 7 days can, at 3 months, show slightly better efficacy than not using any NSAID or steroid as well. And the COAST trial is a trial that is being worked on right now. I'm actually starting to be part of that trial as well, which is looking at randomizing patients to lower pressure, power, and doing it every year, regardless. So we're not waiting for the pressure to go up before we true it. It's like a loading dose and keeping it maintained. And so we'll see what that shows us in the future. But I really wanted to end the last 2 minutes talking to you about how do we describe it to our patients? Because one of the, I think, negatives or barriers for surgeons is how do I convince a patient to do a laser versus drops? Right? Drops seem safer. The way I use, the terminology I use, and the confidence in which you describe it is so important. Patients can pick up on your comfort and confidence. So I tell patients, Mrs. Smith, I'm going to use a beam of light that's going to rejuvenate the natural drain. It's going to use your natural enzymes to excite your tissues to open up those pores naturally. In the US, it's covered by insurance. It just takes a few minutes to do, and you get to go home without any kind of barriers to post-op recovery as well. So these are the key phrases. Now, if they say, is it a laser? Yes. Just like a laser pointer we use for the laser, it doesn't hurt you. It is actually something that just excites the tissue. So these are things that I use. I do think also it is important to recognize the impact of taking someone off of one drop. We have found in our office that we published and presented at ESCRS a few years ago, by getting rid of one topical glaucoma drop, you can save an average of 4 minutes of tech time per patient per visit, because you save time on the callbacks, on refills, on confirming there's a patient on the right medications. So it's significant impact there. Cost savings to the healthcare industry. Looking at the LIGHT trial, the UK saved a significant amount of money, and previous studies have shown significant savings to the healthcare as well as the patients by getting them off of topical drops as well. So in a nutshell, I think that I'm going to fast forward through here as well, just because I think we have a lot of time. But I do think first line makes sense. It's physiologic. It helps address compliance, prevents surface issues. We still have opportunities to put drops if we need to as well. And in my opinion, it gives us an understanding of where the resistance to outflow is. If it works on the level of the trabecular meshwork, and it doesn't work because it works about 80% of the time, that 20% of the time that SLT does not have efficacy, does that tell you the resistance is in the canal or the distal channels? Does that help you decide what type of MIGS to perform as well? So there is a diagnostic potential in my opinion as well. So a lot of rewards, taking control back to us, not worrying is a patient taking medications or not. A huge, huge benefit for us, long-term control of glaucoma as well. I think the type of laser we use makes a difference as well. And my new regimen here, laser first line, MIG second line, more laser, then I'll do a trab, and drops are there as needed as well. Thank you so much for the opportunity as well.
Nice presentation, Paul. Is there any question in the audience for Paul?
Go ahead, please.
What about the women in pregnancy, and you can use eye drops in those cases?
Yeah, no, that's a good question. I think there's a lot of questions, a lot of uncertainty of using any topical medication because of systemic absorption, like beta blockers and others. And I think that's a great opportunity as well. Even those patients who have unilateral glaucoma, where there's maybe more in one eye than the other, putting a drop in one eye can cause hyperemia, cause lash issues as well. So it's a great opportunity for those patients.
What is your schema? You make one session of SLT, and how long do you wait to the results?
So the full effect can take sometimes 4 to 6 weeks to see the results. So I don't really tell the patients I'm not going to decide if it worked or not for about 4 to 6 weeks. I'll see them usually about a couple weeks out, and then if that looks good, see them about another month later, and then kind of decide. Usually I don't repeat it unless I had some efficacy. If I do 360 degrees with every session. I don't do 180 in general, but I do 360. If it did not have an effect, I don't do a second one. If it did have an effect, but starts to wane, then I will do a second treatment even at 3 months if I need to.
Okay. And also, do you use it in ocular hypertension?
Absolutely.
Absolutely.
Absolutely. I have a long spiel on that, but yes.
Okay. Any question for the audience? We have plenty of time. Yes, please.
So I do one 360-degree session, and that is my litmus test. If it does work well, and let's say it starts to climb up even at 3 or 4 months, 6 months, I will repeat it. If after one session of 360 it did not do much, I don't repeat it again. That's probably a patient who maybe has resistance beyond the TM. But I'll do a second or third session over time if it did have an effect initially.
Paul, many people is afraid because the experience with ALT was it causes damage in the trabecular meshwork, and some people begins always with 180. But I realize that 360 is the best option. Are you agree about that?
To me, we don't know where the resistance to outflow is. We also don't know where the distribution of the collector channels are. There are many data sets out there that show us that the distribution of the collector channels are not equally distributed. And number two, the canal collapse and the kind of the patency of the canal is also not equal 360. So we can hedge our bets better by using 360 degrees of laser and then deciding if it worked or not. So I'm a big fan of 360 first line as well. And so to me, the fear of ALT versus SLT, I do agree, ALT does cause destruction, but SLT does not. I have done a number of canaloplasty procedures after SLT. In fact, what I wanted to get to, and I didn't have time, was I have a data set out there we're working on getting published where we had failed SLT, did canaloplasty, then did SLT afterwards and found a significant effect. So to me, I think SLT is a great diagnostic tool to tell us where the resistance to outflow is.
You have a question, please? Good question.
Absolutely. So I'll tell you why. So Ken, the question is, if you have a trabeculectomy, is SLT even worthwhile doing? The bigger question, I'll answer that in a second, is do we think we can reestablish outflow of the conventional pathway once we bypassed it with a tube or a trab, right? I thought no initially many years ago. But I have now not only done SLT, but even stenting. We have something called the Infinite trial with Glaucoma showing us that those 3 stents have significant efficacy. And SLT can benefit. Now, you may have a little bit less efficacy in some patients, no doubt. But the safety being so high, it's still worth it to maybe get them off of 1 drop. It won't get you down to target pressure of 10, but it can get you some reduction as well. So it's worth a try, even after MIGS. Let's say you do your eye stent, or you do your canal dilation, your goniotomy, and you still have some area of TM left over, but the pressures are not where you want it to be, and the patient's not happy going on drops. A great opportunity to say, let's try SLT to augment what I did with my MIGS procedure.
Okay, there is no question. No more. One question?
Yeah.
The last one? Yes.
One more question, sorry. From a corneal perspective, what do you see the role of SLT in patients who've had corneal grafts and the pressure problems that you can get from that? Is it effective in those situations, or?
Sure.
What's your experience?
So the SLT and post, DSAC, DMAC, even PKs. Yes, it can be if you have the anatomy still good. Sometimes after a lot of these surgeries, the anatomy is not quite as good to see. But if you have a good TM that you can see, I think it's a great opportunity to get them off of any topical medication if you can as well. So depending on the anatomy, it's worth a try. Absolutely.
Okay. It's okay.
One more. Sorry.
We have plenty of time. We have plenty of time.
So when do you stop the medication post-operatively? Great question. It depends on how advanced the glaucoma is. If I have a very mild to moderate patient where I'm, let's say, on a PGA and that's it, let's say that's it, monotherapy, I will stop it right away and just see how the pressure does. If they're on multiple medications, let's say a PGA and let's say combination medications, I'll stop the PGA, keep my aqueous suppressants for now, and then at a month see how they're doing, then take them off others if possible. If they're more advanced, I will keep them on everything until I can confirm that they're doing well, then take one at a time away. So depending on how severe and the number of medications is how I dictate how often or how much to take away.
Last conclusion. I have a question for the audience. Why you don't use SLT as primary treatment? If I offer you as a patient that you will have drops every day, 2 or 3 times in a day, during a long time. And in the other hand, I have a procedure, 1 time, 5 or 6 minutes, and then, I don't know why, if someone asks me, what do you want? I realize when I had conjunctivitis or everything, my compliance is terrible. And I believe everyone in this auditorium should be the same idea. Why we don't change our mind? Last question to you. And thank you so much, Paul, for the brilliant presentation.